Hello everyone. Have you covered childhood asthma guidelines? No.
What? Sorry.
Have you covered childhood asthma guidelines?
Yes, a little bit.
Okay, that's perfect. Nice. So basically, if you have the basic concept of childhood asthma guidelines, which we have already covered in so detail, that would be so easy to understand the adult asthma. This is basically considered a nightmare for the AMC because there are many questions regarding this topic. And sometimes these questions are so confusing that how you're going to step up or step down the approach, what is the treatment strategies, what are the important investigation related topics. So asthma is a very, very important topic for your exam. Okay. There is no chance that you are not getting question from this topic. So important thing is first of all, what is asthma? We have just discussed yesterday about the COPD. So it's easy to compare the two things together, asthma versus COPD. So what is asthma? It's basically inflammatory disorder that is blocking your airways. Okay, airway compromise or airway obstruction is there. But the important thing is this is reversible. We all know this is reversible. So you are going to have the typical features of wheezing. This is a very hallmark feature of asthma. And you have shortness of breath, you can have cough, but cough is not a prominent feature. Cough is more prominent in the COPD. Asthma patient can have cough, but maybe they do not have cough at all. So we do not consider cough as a very important feature of this asthma presentation. We consider this wheezing, tightness in the chest. This is the most important feature. So tightness in the chest and the variability. The patient is not in a you can say in a baseline state or uniform state in whole of the year, whole of the day. That is not possible. Sometimes the symptoms are exacerbated, sometimes the symptoms are absolutely normal. So there is a variability. It is a part of asthma. Then very important thing is triggers of the asthma. You won't believe that there is a question of recall in triggers related question also. So asthma is a very, very important topic. Each aspect of the asthma is important. So we have important triggers of the daily basis like pollen, very important trigger. You have dust, an important trigger. If the child has hypersensitivity, even he is allergic to carpets, dust, pollens, animals. These are all allergen triggers as asthma. Cold air, change of weather, this is very important. Then there is a specific entity, specific term. This is known as exercise-induced asthma. So exercise is itself is an important presenting feature of your asthma. Okay, so exercise, do not ignore this presentation. Then you have some infections. Smoking has a very important role in the COPD, but it can also exacerbate asthma also. Then strong odors and sometimes stress. So these are all your trigger factors for the asthma presentation. Very important one. Now, if you have considered asthma, any of these symptoms are there, let me ask you a question. If a child presents to you 6 months of age, okay, 6 months of age child, he presents to you with the typical features of wheezing, he has shortness of breath, you auscultate the child on examination, there is widespread wheeze in whole of the chest, and there is decreased oxygen saturation also. He has intercostal recessions, that means there is something increased work of breathing. So what is the diagnosis? Age is 6 months of age, okay, and all these features are present. So what is the diagnosis?
Bronchiolitis.
Excellent. So this is bronchiolitis. Okay, this is not asthma. We have already discussed in the pediatric discussion about the bronchiolitis. So be very clear about this topics that any patient who is presenting to you with the exact features of the asthma, but the age is less than 1 year, you do not label that patient as having asthma. Asthma never presents before the 1 years of age. That is bronchiolitis, and bronchiolitis is a clinical diagnosis. You do not need even X-ray. You do not need spirometry. Neonate cannot perform spirometry. So this is a clinical diagnosis. And interesting thing is that you do not need any kind of treatment. Okay, that is self-resolving until unless the patient is having so compromised airway, patient is presenting with a hypoxia, then you need to give some kind of symptomatic treatment or support. Otherwise, it's a clinical diagnosis. You do not need treatment, just a symptomatic treatment, and less than 1 year of age, never asthma. These are all your equal questions. These all three features which I have just discussed: diagnosis, treatment, and your management regarding the bronchiolitis. So remember that term also. So asthma, less than 1 year out. More than 1 year, any patient who is presenting with these features, that is definitively asthma. Asthma mostly is a clinical diagnosis, but we need some clue regarding the asthma diagnosis, which is very important. Gold standard, you can say, that is spirometry. Okay, so spirometry, why we are doing spirometry? Because we have to differentiate between the asthma and the COPD. The only feature that is visible on the spirometry is going to be your reversibility, which is a hallmark of asthma. Now, what is the diagnosis of asthma we have discussed so far? Typical symptoms are going to be there. Wheeze is there, breathlessness is there, chest tightness, cough is there, and it vary in frequency and severity from time to time. So this is a very typical presentation of asthma. And second most important thing is the variability. So variability in your airway inflammation. Sometimes he's mild category, sometimes he's belonging to moderate category, sometimes severe category, and your expiratory flow, which we consider it as FEV1, and we do spirometry to monitor the FEV1. So these are two are very important with respect to your asthma diagnosis. Now comes that how you are going to perform this spirometry, or if the patient is not able to perform the spirometry, then what are the other options for the diagnosis of your asthma. So first of all, spirometry is your gold standard. What is spirometry? First of all, should have an idea that what is spirometry. This is spirometry. This is a device, and you have a computer attached that gives you a graphic presentation. We have different lines, different volumes of the air that is recorded as a graph presentation, and you just read that, and you monitor the lung functions according to that graph or parameters. So patient just sits, nose is obstructed, or you put a clip onto the nose. He takes first deep inspiration, then expiration, and according to that, you measure the volumes of the lung: inspiratory volume, expiratory volume, total lung capacity, residual volume. You do not need to go into so much detail of spirometry, that what are the volumes, how we are going to measure. This is not tested in exam. Just have a brief idea that this is a spirometry. Okay. Now, spirometry, first of all, you take all the volumes of actual patient, that forced vital capacity, FEV1, ratio, peak expiratory flow, then your peak expiratory flow, normally it's 25 to 75%. So these are all the definition, that what are the different parameters which are measuring on the spirometry. Normally, our spirometry is more than 80%. That is good. All the volumes are more than 80%. That means absolutely fine. And your ratio normally is more than zero point 0.7. So we have very important clue that if your ratio is decreased, this is a very important term. FEV1 to FVC ratio, if this is decreased less than zero point 0.7, that is obstructive lung disease. In that we also discussed yesterday, that obstructive lung disease, you have two features. You have asthma or COPD. Only these two things are obstructive lung disease. So your ratio is decreased in your obstructive lung disease. And R for restrictive, R for ratio increased. So your ratio is raised or increased, that is in restrictive lung disease. So anything that is left in the respiratory portion beyond your asthma and COPD topics, that are restrictive lung disease. So you have pulmonary fibrosis, you have ILD, you have sarcoidosis, pneumoconiosis, occupational related diseases, anything. You name the diseases, that would be there. So there is a list of disorders in the restrictive lung disease. These are all raised ratio disorders. Okay, FEV1 to FVC is more than zero point 0.7. So remember this zero point 0.7. This is very important. Then you have make the diagnosis that your ratio is decreased or increased, so you are stuck that whether I'm talking about the asthma or COPD. So next step is you will give bronchodilator. Okay, during the spirometry, you have first measured these parameters. You have get this decreased ratio. You are not sure this is a patient of asthma or COPD. Now you are giving bronchodilator. After bronchodilator, you again take the volumes, FEV1 to FVC ratio. If there is a reversibility, that means ratio is somehow improved after bronchodilators, that means you are talking about asthma, because reversibility is demonstrated. So you are talking about asthma. If there is still the same volume which we get before bronchodilator administration, that means you are talking about COPD. That means non-reversible condition. So this is a basic concept of spirometry. This is a basic concept of reversibility. So spirometry is ideal situation. Spirometry you have to do as a diagnosis of asthma, which is a gold standard investigation. But sometime the patient is not able to undergo spirometry, the maybe he is having some kind of restrictions or anything. So if spirometry is not available within the practice, like in a setup where the spirometry is not available, or there is some restriction from the patient part, then what is the next step? So next step is going to be your pheno. Pheno is fraction excretion of nitrogen. Okay, so this is pheno. This is also important test. So you can measure this pheno also. Sodium excretion, fractional excretion, basically we measure. So again, you go for the reversibility, FeV1 plus pheno. These are two important things. But still, if this is not available, you just treat the patient as asthma. You do not delay based upon the investigation available or non-available. You treat the patient. You give the bronchodilator. If symptoms are reversed, that means you are talking about the asthma patient. That is very evident from the clinical perspective. So these are all the important points with respect to diagnosis of the asthma. Now, important thing is that if the patient is having FEV1 less than 60%, like patient is presenting to you in acute exacerbation, FEV1 less than 60%, remember, less than 60% mean the COPD is so worse or the asthma is so worse. So this is acute exacerbation. You do not perform that bronchial provocation test or spirometry in these patients. In acute exacerbations, these tests are not performed. Even in pregnancy, the bronchial provocation test, these are contraindicated. So these are two, 3 points which are important with respect to your diagnostic point of view. These are from Asthma Handbook of Guidelines. Okay, Asthma Handbook is a very large kind of book, but you do not need any word-to-word reading or all the concept that is written in there. You just need flowcharts and the important points, bullet points, or important summary kind of things that you just go through. So whatever is important, I have just put in into this presentation. Then spirometry we have covered. The next important thing is that when you are taking the history, you have to cover all the allergens which we have talked so far. So important thing is symptom. You have to ask about every symptom: wheezing, breathlessness, chest tightness, cough. Then pattern of the symptom, that whether the patient is having daytime symptoms, nighttime symptoms. This has very important significance. Why? Because if the patient is having nighttime exacerbation, that means you are dealing with the severe asthma. Okay, because many patients have so much allergen, so much exposure in the daytime, but nighttime is somehow calm. You do not have that much exposures. But if the patient is having nighttime symptoms, that is alarming thing. Okay, nighttime symptom, we take it seriously because the patient can deteriorate at the night. So this is not something normal. So nighttime symptom itself is telling you that the patient is having severe disease. This is important one. Then provocation symptom, that whether there is a specific provocating factor, exercise, viral infection, cold air, foods, medicines, everything you have to ask about. Smoking history, very important. Vaping history, very important. Allergens, you have to rule out because sometime a young child presents to you, he is atopic, he's having so much allergic phenomena, he's having allergic rhinitis, sinusitis, these kind of things. And these allergens are basically exacerbating the asthma again and again. So you have to control that atopic conditions also. So this is important one. You have to take the history of allergens also. Then family history of asthma. Sometimes this gives you a clue that family history of asthma is positive, allergies is positive. So maybe you have narrowed down your approach or narrowed down your diagnosis that you are dealing with a patient of asthma. So these all things are important with respect to your history taking and examining the patient with respect to triggers. Triggers, you have to remember all the triggers. Okay, these all the triggers are important. Now they are not very straightforward question. They are more likely diagnostic and management point of view approached question. But earlier, if you read the AMEDEX and even in past pools of the recalls, there are very clear MCQs, one-liner MCQs also. So they used to ask about these triggers, that which of the following is not a trigger of asthma or which of the following is a trigger of asthma. But now the approach is more towards the management and more towards the investigation. But still, this is an important topic. So you cannot ignore these parameters. If they have asked in the previous recalls, they can ask now also. Okay, so remember all these triggers, these are important ones. Now, the important questions which we have covered so far, certain symptoms and sign that points you away from the asthma. These are also there. So we have certain symptom and sign which makes high probability of asthma, and there are certain symptom and signs which makes low probability of asthma. So these are important ones. That which of the following are high probability and which of the following are low probability of asthma. High probability, which we have discussed so far. All these things, that means these are the very typical symptoms of asthma. High probability. There are very high chance that you are dealing with actual patient of asthma. That is understandable, very clear. Low probability of asthma, anything that is deviating from these symptoms, that may be uh, taking you towards the alternative diagnosis. That can be your, let's say, dizziness, lightheadedness, the patient is having tingling, the patient is having cough, not other respiratory symptom, chronic sputum. So we know cough and sputum, this is a more diagnostic feature of COPD, not the asthma. Or if the patient presents to you with a heavy smoking history, then again we will think of some cancer related problems, some COPD, some in that ILD patients. We will not think of asthma clearly. Heavy smokers are not that much important for the asthma as compared to COPD. So you have to rule out the things less likely and the more probability symptom. Just have a look at this a chart, whatever is written. Not very important for your exam, but important thing is that you should be clear that these are the features which are pointing away from the diagnosis, and these are the features that are in favor of your diagnosis. So one very important feature that is a very strong association with your diagnosis is the symptoms that is responding to your bronchodilator therapy. This is very important for your exam, that if the patient is responding to bronchodilator therapy, that is a clinical evidence that this is a patient of asthma, because asthma always responds to bronchodilator. If there is no improvement after bronchodilator, we are not talking about how much improvement. There are chances that you are giving SABA or you are giving first line treatment, the patient is not responding completely, and you step up the approach. But the thing is that there should be improvement. Maybe there is not complete resolution of symptom, but somehow the symptoms are going to be improved. This is a very hallmark feature of asthma. So if the patient's features are not improving, again, this is pointing away for the diagnosis of asthma. This is important one, okay? So probability of asthma. This is telling you about the probability of asthma, that which features are pointing towards the diagnosis of asthma. Then this is approach to asthma, that a patient presents to you. He is having wheezing, he is having breathlessness, chest tightness, cough. These are the four very important features of asthma. You have to remember as such. So you take history, you take physical examination, whatever we have discussed so far. If on history and clinical examination you are suspecting that the patient is having asthma, but spirometry is not available, that means you cannot perform the spirometry, you cannot go for investigation in any way, treat as asthma. Okay, because clinically you have labeled the patient as asthma, so definitively he is going to respond to the bronchodilator therapy. So if you cannot go for an investigation for further confirmation, treat as asthma. Second important thing, if the patient history and physical examination, they are not giving you some alternative diagnosis, like they are very suggestive of asthma and spirometry is available, go for spirometry. Okay, and spirometry, what are the parameters you perform spirometry, all the features like FEV1, FVC, TLC, everything before, and 10 to 15 minutes after bronchodilator therapy. Okay, so 10 to 15 minutes is important. You give the bronchodilator therapy, after 15 minutes, again, you check the all lung functions and whatever the differences are, you compare. Then FEV1, this we also discussed yesterday, that earlier it was said that 12% is very important for your FEV1, but in new guidelines in e-medicine also, they have somewhere they have also mentioned 10%. So you have to remember both. In asthma handbook, they have mentioned 12%. In e-medicine, in some question, they have mentioned 10% also. So be familiar with all both of these conditions. So more than 12% increase FEV1 or more than 200 ml, this is diagnostic of asthma, or FeNO more than 40 pheno, this is diagnostic of asthma. So these values you have to remember. If this is not available or if spirometry is not suggestive of asthma, think of alternative diagnosis. If asthma diagnosis has been confirmed, treat as asthma. So this is a very basic approach. Whatever we have discussed so far, this is summarized in this flowchart. Then if you have established the diagnosis, okay, I'm dealing with a patient of asthma. Next important category is you have to categorize while my patient is having mild asthma, moderate asthma, or life-threatening severe asthma. Because according to that, your treatment is going to be changed. So first of all, what is mild or moderate asthma? So mild to moderate asthma, remember the patient can walk, he can speak, whole sentence is completed, and your SpO2 that a partial pressure of oxygen is more than 94%. So absolutely normal patient who is giving you history, who is talking to you, he comes to OPD by walking, and he do not need oxygen for the normal day-to-day work. That is a patient of mild to moderate asthma. But as far as the asthma is going into severity, the patient is not able to catch the breath. The patient is not able to hold the breath completely, and he is not able to walk or he is not able to talk. So unable to complete the sentence in one breath, He is very short of breath. And there is increased work of breathing in a normal activity. The patient is having tracheal tug, the patient is having recessions, he's having abdominal breathing or chest wall recession in the children. He is in obvious distress that he comes to you and he is short of breath and you measure the oxygen saturation that is 90 to 94. That means you are talking about severe asthma. So severe asthma, very important feature is this one. He is not able to complete the one sentence. This is severe asthma. Absolutely normal patient is mild to moderate asthma. Then comes life-threatening asthma. This is very important for you to understand. There are so many questions with only this portion, life-threatening asthma. Okay, so you have to uh, take the concept very clearly that what is the life-threatening asthma and what is the severe asthma. Most of us think that wheezing is a very important feature of asthma. So as far as the patient is going into severity, like a severe asthma or life-threatening asthma, there should be more wheezing. But remember, the life-threatening asthma, the patient is going in a silent phase. Okay, so patient will not able to talk, patient will not able to walk, and when you listen the chest, it's going to be silent chest because all the muscles that were working basically in the severe asthma, there were increased work of breathing, accessory muscles were used. There was basically subcostal recessions, intercostal recessions. So all the muscles, they have been tired. Now there is a point that the patient has gone silent. So this patient who is silent, basically absent breath sounds or the soft breath sound, wheezing was a diagnostic characteristic of asthma. So if your patient is not having wheezing, that doesn't mean that the asthma has been improved or resolved. That means you should take it seriously. This is a life threatening situation and all the muscles has gone into into fatigue, that is tired. This patient can deteriorate at any time. So reduced consciousness, collapse patient, absent breath sound. This is a very important feature. You have to remember absent breath sounds. And the next important thing is poor respiratory effort. You are not able to see this recessions and accessory muscle use. He's not able to use the muscles at all. So he has just you can say in a silent phase. So exhaustion or cyanosis and SpO2 is less than 90%. This is your life-threatening asthma. So you have to identify the severity, mild, moderate, and severe asthma. Next important thing is now treatment. This is nightmare for your asthma, that how you are going to treat the patient of asthma. So earlier, if we have a basic concept from our medical degree or whatever we have used to treat the asthma previously, what was the first line treatment of asthma as a medical student? What we were taught that if a patient
Um,
presents to you,
Saba.
Saba, excellent. So mostly what we used to do, we have given so many, we have treated so many patients of asthma in our life. So what we used to give, we give Saba. This is a first line treatment of asthma. But this is changed now. According to new guidelines, Saba is not recommended as monotherapy if you are maintaining the patients. Okay, this is just you can say change maintenance therapy. So if we are talking about maintenance therapy, there are two concepts. Remember, there are reliever concept and there is a maintenance concept. Reliever mean absolute symptoms are control, emergency department, and maintenance mean take home medicine that the patient is what the patient is taking on a regular basis. This is maintenance therapy. So we are talking about maintenance right now. We are not talking about reliever right now. Okay. So maintenance therapy. Remember, we have two important treatment ladders. Remember, we have two ladders, and you do not that mix that two ladders together. Just take two ladders separately. If you are treating patient on this side, you have to use this side step up approach. If you are treating the patient from this side, you have to use this side step up approach. Okay, you cannot mix the patient that he is coming to you earlier. He was taking this, and you shift the patient to this one. This is not acceptable. So you should be very clear that which treatment ladder you are following or the patient is taking. So be clear about these two treatment ladders. Now, maintenance therapy, even with first line, remember this is very important. Even with first line, the patient is having mild symptom. The patient is not in a very you can say exacerbation, nothing. Even with first line, your SABA is not there. Isolated monosaba therapy as the maintenance has been obsoleted. Even your patient is having very controlled symptom. He's having excellent control of asthma, but he needs some kind of maintenance therapy. You have to give for either budesonide formoterol, low dose. Okay, budesonide is your steroid, and formoterol is your what is formoterol?
It's Laba.
Yes, so formoterol is basically your LABA. Okay, so be clear about this. This is your LABA, LABA. So this category is LABA ICS combination. One flowchart. One flowchart is your LABA ICS combination. You have the option that at very first presentation, this is a patient of mild asthma. As a first line therapy, you start the patient onto the LABA ICS combination, but low dose. Okay, you start the patient with a low dose LABA ICS combination. Then you monitor the patient whether he is responding or not. If he comes to you that I'm not responding, then what you are going to do, this was SOS basis. SOS means as needed, that whenever he requires something, just take 2 3 puffs of this LABA ICS combination. He is not responding to that medication. He comes to you that doctor, I'm having again so much exacerbations, or my symptoms are not controlled, I'm not able to work properly. So what you are going to do, that ICS formoterol, same budesonide and formoterol combination, you will put it as maintenance therapy plus reliever therapy, that you have to take this combination on daily basis also, and whenever you are feeling exacerbation increased symptom, take additional dose of same puff, same whatever the medication you are using. Okay, so remember this, we are talking about one pathway, that ICS, LABA ICS. Remember LABA ICS, LABA ICS as needed therapy, then you step up as LABA ICS as maintenance plus same medication as reliever therapy, low dose. Then, if symptoms are not controlled, he is already on the maintenance therapy. He is already on a combination of reliever therapy. So, what you are going to change, you are earlier prescribing the patient low dose. Now, what you are going to do, medium dose. Okay, you are increasing the dose of the patient, nothing else. Okay, so medium dose and low dose. So easy to remember if you have clear concepts. So just follow the one flow chart. Do not mix with the second one. You have one flow chart, you have LABA ICS. Just remember the word LABA ICS, and be particular what is LABA, because in options they will mention formoterol, they will mention salbutamol, so you have to choose accordingly. So LABA is your formoterol, this you should be clear. Then after this formoterol, LABA formoterol, first of all, you started the patient on SOS basis. That means as needed basis. SOS is basically as needed. So as needed, he's taking as a reliever, LABA ICS. Not control, you put the patient onto the maintenance plus reliever. He's taking daily doses. Not control, you are increasing the dose. Medium dose you have shifted, maintenance plus reliever. Still not control, then you refer the patient for the specialist treatment. So all this flow chart, you have just given one treatment, that was basically your formoterol and ICS therapy, LABA ICS therapy. So easy, okay? Just step up approach as needed, low dose, medium dose, and maintenance therapy. Now the second flow chart. Second flow chart is that you start the patient with the ICS maintenance therapy. Even he was a mild case. He was presenting to you that my symptoms are absolutely fine. Now you want to step down the medication, that this should be the minimum medication he can use on daily basis. But on minimum medication, even you are giving some maintenance therapy as a daily basis. Okay, so this is an approach in which you are giving patient ICS as a maintenance low dose alone. Okay, steroid as a low dose alone, plus whenever he needs he can use SABA as a reliever therapy. But we are not giving SABA as a monotherapy. We are not saying that whenever you need, just take the puff of SABA, and on daily basis do not take anything. This is not recommended. So ICS on a daily basis low dose, and as a reliever he is taking SABA therapy. If it's not controlled, then you are going for same flow chart, just this kind of flow chart. Just remember this, make a visual memory of this, that ICS LABA you are starting as a maintenance dose, or you can say rather than this one, you can just this thing, that this thing is same, these two parts are same for the flowchart. You are giving patients LABA as a low dose ICS formoterol therapy, but along with that you are giving SABA as the reliever therapy. Okay, in this your reliever was also same, ICS formoterol. LABA ICS was your maintenance, LABA ICS was your reliever. But here LABA ICS is your maintenance, SABA is your reliever. Okay, so we have two flow charts in which we are preferring SABA as a reliever, or we are preferring LABA ICS as a reliever. Okay, so this is the main difference. Then patient not controlled with this low dose, you step up into the medium dose, same thing. But as a reliever, you are using SABA. Or same, still not controlled, you are referring the patient for the specialist. So it seems to be tricky, but this is so easy. This is not very complicated. Just you have to make concept that you have two parallel flowcharts. In one, we are using SABA as a reliever, but never the monotherapy. Never. Okay. SABA is not used as a monotherapy, it is used as a reliever. Along with that, we are giving some kind of maintenance therapy. Or in second option, you are using LABA ICS as a reliever. Okay. So these are the two flowcharts. Be clear, make a very clear concept, do it again and again, and this is how this is going to solve all the questions. Any question up till now?
Why there are two charts? I mean,
There are different indications with respect to different patient, different studies. According to that, different guidelines or all the things together, they have whatever they have studied, they have just compared the two approaches for the treatment of asthma. Like we do in hypertension, we have many options of hypertension as a first line treatment. We can start ACE inhibitor, we can start calcium channel blocker because they are different studies. So it's your choice whether you are giving ACE inhibitor as a first line treatment or you are giving calcium channel blocker as a first line treatment. So same is true for this asthma medications, that there are so many studies
so
and they have given you two options that either you can
okay.
choose this one or you can choose this one. Okay. So this is
So
important thing.
the question will come if the patient was earlier using ICS maintenance and SABA reliever, then we will go flow the second chart as
Yes,
the
we you have to
next
you have to
investigation.
very clear that you do not merge the two flowcharts. Okay, so whatever they are
Okay.
mentioning in the question, go according to that flowchart. This is your concept building. So if they are mentioning that the
Okay.
patient is taking ICS and SABA as a reliever, then you have to go for the ICS LABA maintenance plus SABA as the reliever. You
Okay.
cannot omit the SABA and go at this stage that okay, I'm giving maintenance plus reliever this thing. Whatever he is taking, go according to that flow chart. So this is important.
Okay.
Just go for step up approach. Understand this flow chart again and again till your exam. This is very important for your exam. So this all you need to remember this flow chart. This is the you can say take home message. Then this is very important thing that Australian asthma handbook, they guide you according to the treatment. What is the treatment? Basically level 1. Level 1 mean the patient is presenting to you as a mild treatment. So mild treatment, what you are giving? Low dose budesonide, formoterol as needed. This one we mostly, if someone asks you that which flowchart is more beneficial for the patients as compared to the other, so this is more beneficial because there is no hassle that you have to switch to the reliever and maintenance therapy. You have only one puff available. Whatever, whenever you need, you take it as a maintenance, you take it as a reliever therapy. So this is more preferable, easy to guide, and the more easy to use for the patients also. So Australian guidelines, if they want, if they prefer, they say you that you use low dose budesonide formoterol. That's difficult to remember that it as budesonide formoterol. It's more easy if you just make the concept of LABA ICS. Okay, so LABA ICS easy to pronounce and easy to remember. So LABA ICS, but be clear that LABA is your formoterol. So first of all, LABA ICS as needed. Then you have step up LABA ICS as a low dose maintenance therapy. Then LABA ICS as a medium dose maintenance therapy. And according to that, you have add on the therapy or you refer to the specialist, whatever. So this is same thing which we have just discussed. And the important thing is that what we used to do earlier, which we prescribe the patients earlier, SABA only treatment. This is not recommended. Never recommended in any situation. This causes more serious exacerbations. A SABA only treatment. So never choose SABA only. You have to either go for SABA plus ICS or you have to go for LABA ICS combination. So only this is the take home message. This is the tricky thing of asthma. This is very clear in these slides. Okay. Next important thing is this is from therapeutic guidelines. Same thing, same repetition is there. If a patient comes to you with the mild to moderate, you give solbutamol by the meter dose inhaler. Then severe patient, you step up into the solbutamol plus ipratropium. Life-threatening, you step up into the solbutamol ipratropium. According to oxygen inhalation, you give oxygen also. This seems to somewhat tricky. We will come back to this after the concept of inhaler and spacer. So what is the difference between this spacer and inhaler? In PEDS, we have discussed this, that what is the difference between spacer and inhaler and what is the preferable condition?
Spacer is preferred, I think. MDI spacer.
Yes, MDI is meter dose inhaler. It is inhaler, okay? And this is spacer
Okay.
plus inhaler. Spacer is basically this device. which we mostly use. This is inhaler. Most of you have seen this. This is inhaler. That this is basically a condenser. This is medicine. You put it into the, this is plastic framework kind of thing. You put it into that plastic framework. It gets attached to that, and then you consult the patient. First, you take a deep expiration. You maximum whatever the air is into your lung, you have to blow it out. First of all, this one. And then you put this inhaler into your mouth with a close, tight contact, and maximum to which extent you can inhale, you have to inhale, and along with inhalation, you press this down. So by pressing, you are having one puff. Okay, one puff of medication is going into that inhaler, and you have to inhale it with your inspiration. So it totally depends upon capacity of the patient to use, that during inspiration he is pressing the medication or not, what to what extent he is able to inspire that medication. So it entirely depends upon the patient's use. If the patient is not first blowing the air out and then forcefully taking the oxygen in, he is not taking medication into the lungs definitively. So this is entirely patient dependent. So any child who is very young, he cannot use this inhaler, meter dose inhaler. This is understandable. So the alternative option is spacer plus inhaler. Spacer is basically, you can say, a suction device. Just remember, this is not actually suction device, but to make a concept that this is like a suction device, we attach it with the inhaler, and this is something like this. It becomes like this. Now, whatever the effort of that sucking the air in, that is bypassed. So somehow it's not patient dependent. So what you are going to do, you will just take a deep breath, normal deep breath, not coordinated with the medication pumping, no, not coordinated with expiration, inspiration. You just take a slowly deep breath, and the medication is going into the lung. So somehow it's easy to use. So if we someone asks you that inhaler is best or spacer plus inhaler is best, to remember spacer plus inhaler is very best, specifically for the children. This is very important. So this we have made the concept that spacer plus inhaler is the best technique that we can give to the patient. And technique is very important because sometimes patient you are giving the treatment, and treatment is absolutely right according to the grade of the patient, but patient is not able to take the medication. So if he is not able to take the medication, then what's the point of prescribing any other medication? So this is important one. Just a minute. Okay, so next important thing is how you are going to manage the asthma. This is basically your this one, this easiest summarized way of this flowchart. We will come back to this flowchart, but the easier you can say pictorial representation, easy to remember, easy to understand is this one. So mild, moderate, severe, you have categorized the patient according to that. What we have discussed this from this flowchart, we have make an understanding of step up or step down approach. But now we are applying that flowchart according to that patient, because we have make our understanding that this is how you have to step up or step down. But what if a patient comes to you with a mild moderate, then what is the initiative point, or from which part of the flowchart you have to start? Now this is the implementation. So, first of all, mild, moderate, severe patient. Mild, moderate, severe, the concept was very clear. He's able to talk, he's not able to talk, he takes some short breaks, and he's very breathless. He cannot talk at all. And after this, the life-threatening asthma comes, which is sinused, silent chest, and everything like this. So, severe and life-threatening is something alarming. Now, if a patient comes to you with a mild therapy, remember, we can take reliever as a salbutamol with spacer. This is basically acute exacerbation. We are not talking about maintenance therapy. Do not mix the two concepts together. This is acute exacerbation. That means the patient is in emergency department. You are working in emergency. You have to relieve the symptoms. This is not something the patient is home. You have prescribed the medication that whenever you have exacerbation, use this, and daily basis use this. Whatever the flowchart was, this was according to maintenance therapy. Okay, so do not mix the two things together. This was maintenance flowchart. Now the patient is having acute asthma. He's in emergency situation. You have to use something immediately. So what you are going to do, mild patient, if he comes to you in an emergency, what you are going to give? you are giving, first of all, meter dose inhaler with spacer. This is your priority because spacer is good to use. You give reliever therapy as solbutamol. What is solbutamol?
Saba.
Just a minute. Okay, so giving reliever for the acute exacerbation, SABA. Okay, so solbutamol we are giving just a solbutamol for the mild cases in acute asthma. You are giving four puffs one time, and after every 4 hours you are repeating. So basically, we consider it as 4 to 4 rule. 4 puff, 4 hour, 4 puff, 4 hour. Okay, so you can continue this up to 4 rounds. 4 puff, 4 hour, 4 puff, 4 hour, 4 puff, 4 hour. Up to 4 times you can continue this. 4 into 4 into 4. This is known as 4 into 4 rule. So this is a reliever therapy. Patient will be all right after this, absolutely normal. If he is coming to you and you think that he is a mild patient, but somehow the symptom needs to be relieved quickly, then you have the option. You can also use corticosteroid. But we mostly do not prefer this oral medication. This is enough for the patient. If the same patient comes to you in moderate category, shortness of breath, not able to speak in emergency department, what you are giving as a reliever therapy, you are giving solbutamol, but now the duration is less. Earlier, you were waiting for the 4 hours, 4 into 4 rule, but now you can repeat that 4 to 8 puffs after every 20 minutes. Your duration is shortened. And along with that, just salbutamol is not enough. Just SABA is not enough. You are adding ipratropium bromide also. So 4 to 4 rule, same. 4 to 4 puffs, you have to give every 20 minutes. Back to back 20 minutes, you are giving this combination therapy. So this is SABA. And what is ipratropium?
Sama.
Uh, okay, Sama or Lava or Lama.
Uh, I think Sama. Short acting muscarinic.
Ipratropium basically,
Theotropium is Lama.
yes, ipratropium is basically anticholinergic medication. Okay, so anticholinergic medication, this is Sama. This is Sama. So you are giving Saba plus Sama combination back to back every 20 minutes. This is for moderate category, acute exacerbation. Again and again, I'm saying that this is acute exacerbation. Do not mix it with the reliever therapy. Whatever the concept you have taken, two pathways that were for reliever. In reliever, the maintenance basically. In maintenance, we do not prefer solbutamol alone ever. Okay, so that was maintenance therapy at home patient, maintenance patient. This is acute patient in emergency setting. So you can give mild patient just Saba or moderate patient Saba and Sama. If he is severe patient, he is not able to talk at all, he is very severe, short of breath, then again you have the option salbutamol plus ipratropium, but now frequency is more increased. Earlier you were giving every 20 minutes, this was your priority, but now you are giving every 10 minutes or continuously, back to back, continuous inhalation. Okay, so these are the priority. This is important one. In this, you were giving single dose prednisone, but now patient is having severe asthma, so you can give either IV or IM hydrocortisone if the patient cannot take an oral medication. So this is how you have to manage the patient of asthma. Acute asthma, this is emergency medicine. Okay, so remember it as emergency medicine. This is your emergency situation. This is not normal home patient, this is emergency situation. So we have two flowcharts, two easy things to remember, and these are very important. Now what if the patient, after this, the patient becomes absolutely normal? The same concept which we had taken in the childhood asthma management. So if the patient, after coming to you to the emergency department, you give the treatment and he is absolutely fine, he's not needing any kind of further management, but you monitor this oxygen saturation is 92%, will you discharge this patient or he needs observation?
Discharge.
No, thank you very much. I think
No, discharge. Okay, so this is very, very important that if a patient who is absolutely fine, then oxygen saturation is not your criteria for discharge. 90 to 94 is acceptable. 90 to 94, you can discharge the patient with a good, if he is having good management control and he is not requiring any further medication. So take this concept very clearly. 90 to 94 on discharge is acceptable. Now, this is very important. that you have discharged the patient, he comes back to you on a follow up, he gives you certain history. Now you have to assess the patient that whatever the medication he is taking at home, that is controlling the symptoms or partial controlling the symptom, or the patient is having poor control of asthma. So again, this is a flowchart, very important one you have to remember. So good control mean the patient is having daytime symptom 2 times or less. Okay. So daytime symptom, if 2 times or less is there, that means the patient is in good control. No limitation of activity, no symptoms during the night. This is very important. Night symptoms are alarming. So no symptoms at night should be there. This is not acceptable. And need for asthma less than 2 weeks, 2 days per week. So these are important things. 2 times per day, 2 days per week he is having symptom, and 2 days per week he is using SABA. That means good control. Okay. Rule of two. This is a good control. Okay, this is first thing. That 2 days per week he was having symptom. 2 days per week he is using SABA. No night symptom. No limitation of activity. Good control. Partial control means opposite to that. The rule of two is opposite. Now he is having more than 2 days per week symptoms. He is having more than 2 days per week. He is using SABA, and along with that, he is having some limitation of activity. He can have during night symptoms some limitations. He's feeling some wheeze and breathlessness during exercise. So some limitation of activity plus more than two rule. So this was less than two. It was more than 2 days per week. This is known as partial control. Now comes poor control. So poor control, remember, with more than 2 weeks, more than 2 days per week, same rule. But now he is having uh, either three or more weeks or days per week, or the patient is having continuous night symptom. So night symptom is itself very alarming. So if even 2 nights are there, then this is a poor control. Okay, remember this: 2 nights are even poor control. So this is a poor control of asthma. You have to step up these patients. If he's coming to you with this time, and he was taking, let's say, ICS and LABA with the maintenance dose, medium dose, you can step down. You can shift the patient to the low dose. But if he comes to you at this stage and he was taking medium dose, then maybe you need higher doses, or you have to refer to the specialist because the patient is not having a good control of the disease. So this table is important one: good control, partial control, and poor control. So this is important concept. Now the next important concept. Up till now we have covered asthma. Okay, so acute asthma treatment, maintenance asthma treatment, at home treatment, how to discharge the patient, what are the criteria. These are all has been discussed. Along with this is just adult management. Childhood asthma was different, which we have covered in the pediatric discussions. Now comes exercise induced asthma. Okay, so exercise induced asthma is a different entity, separate entity. This is very important, that the patient is having symptom whenever he exercises. So exercise induced asthma is itself very important. Now the important thing is that if the patient is coming to you with a history of exercise induced asthma, you will not say that quit the exercise. This is not recommended. He needs to be active. He needs a step up approach for the exercises. This is important one. Now, how you are going to treat the exercise induced asthma? You have two options. If the patient is having symptom, then before exercise, you can use either SABA treatment, 15 minutes before exercise, use SABA treatment, or you can use low dose budesonide formoterol before exercise. This is as a precautionary measure. Okay, the patient is not having symptom yet, but before exercise, because the patient know I can have symptoms after exercise, so he can use either SABA, or he can use low dose budesonide formoterol as a combination in the, you can say, LABA ICS. Okay, LABA ICS or SABA, both can be used before exercise to relieve the symptom, and he should keep on exercising. So this is the important thing. Now this important thing is take home message, you can say: LABA alone is not recommended for the prevention therapy before exercise. SABA alone you can take, SABA, or you have option of LABA ICS. Okay, LABA alone you cannot take before exercises. So only these two things are very important, you have to remember. Then if the patient presents to you with the symptoms, earlier the patient was not having symptom at all. These are two different concepts. This patient did not had any symptom. Let's say he's your friend, he comes to you, that he says that, yeah, whenever I do exercise I feel something bad. So you say that what I can suggest you, maybe you can use SABA alone, or you can choose LABA ICS combination before exercise, that will help you. So this was absolutely normal patient, just a casual chit chat. Now, this is a patient who presents to you in an emergency department. Okay, emergency department. He undergone some kind of exercise, and now he's actually having exercise-induced bronchospasm. He's in emergency department with the symptoms. So, how you are going to treat that patient? Now, treatment, we do not recommend SABA. Take this concept that SABA alone we do not prefer nowadays. Okay, so in acute emergency, because he's having symptom, he's not in a mild category, he is having severe or moderate category after exercise. So what you are going to do, first line treatment is LABA ICS. This is the first line treatment for the maintenance and reliever therapy for the exercise induced bronchospasm. So if they ask you, they give you both option, do not choose SABA alone. Although your therapy, this is basically from therapeutic guideline, this concept, your therapeutic guideline says that you can use SABA alone, or you can use SABA ICS, LABA ICS combination before exercise. But if you have to choose one thing, this is a first line thing. Always choose LABA ICS treatment as a reliever, as a maintenance therapy when you are giving long term therapy. Okay. So that was something else. That was just a precautionary prophylactic therapy. And this is a maintenance plus reliever therapy. When he is having symptoms or when he is taking long term maintenance therapy, always give LABA ICS, not the SABA alone. Okay. So this is a take home message. Then we have some questions. A 10-year-old boy is brought to emergency department by the parents. He has a history of asthma, for which he takes a regular preventer and needed reliever. So he is on maintenance. He needs preventer as well as reliever. Since developing acute upper respiratory tract infection, so remember, infection is a trigger. So is he having triggered last 3 days? Asthma has been worsened. On examination, he can speak a few words in one breath in sitting up, hunched forward, alert, not sinus. So somehow he's presenting to you in a moderate category. Few words he is able to speak, and not sinus, that means not life threatening. He is having tachycardia, blood pressure is 100/60, respiratory rate is 28, SpO2 is 91. 91 again, remember 94 above is mild, and 90 to 94 is your moderate. So this patient is your moderate category, able to speak in few words, and 90 to 94 is saturation, moderate category. There is a widespread wheeze on auscultation of the chest. In examination, he receives nebulized salbutamol and oral corticosteroid. So remember, in emergency department in acute asthma, what we have just discussed, that in mild case the patient can take reliever and corticosteroid. In moderate case, the patient has to take reliever plus corticosteroid. Oral he can take, and you have the option salbutamol plus ipratropium, ideal situation, but this patient has been given salbutamol and prednisolone. Okay, so he has been treated. Now, what they are saying, that the patient he has been taking nebulized salbutamol and oral corticosteroid, after which he improves rapidly. So symptoms were immediately controlled. That means definitively he was a patient of asthma. Which of the following is the most appropriate follow-up approach? Now, how you are going to follow this patient? What do you think?
Outpatient review in 48 hours.
Yes, this is very important, that first of all, you have to follow up that patient to GP or respiratory specialist. This thing is very important. That asthma patient is treated by GP or respiratory specialist. Remember, in Australia, every patient is almost treated by GP. Every patient, until unless this is an emergency, then GP refers the patient to the specialist. There is no direct approach to the specialist as such if the patient is having a fairly controlled disease. So this is very important, because this is not common in our setup. In Indo-Pak region, mostly we have the access to specialists straightforward. But here, GPs are as a bridging doctors to the specialist. So remember, the asthma patient who is having well controlled symptoms, he will follow up with a GP. He will not go to the specialist straightforward, because the symptoms were controlled. He's having moderate category of symptom. Everything was normal. Patient has responded well. So what your guidelines say? Guidelines say definitively he needs to be seen frequently, like after 2 to 3 days. You need follow up. 48 to 72 hours is recommended, but not to the respiratory specialist, GP. Okay. So after 2 to 3 days, he will come back to the GP, and after 2 to 4 weeks, again he will come back to GP. So two visits are recommended for the that patient of asthma. So this was not related to typical management of asthma, but this is an important aspect. This type of question come in ethics category or the public health domain. These are the mixed kind of questions. So remember these things. Okay. So 2 weeks, 2 days, GP, not the respiratory specialist. Next is 22-year-old woman. She presents to emergency department with a 2-hour history of worsening shortness of breath and audible wheeze. So she is having wheeze and she is having shortness of breath acute 2 hours. She has a history of mild episodes of breathlessness, especially in the winter. So you have a trigger factor winter for which she does not take any regular medication. She has not an attack over a year, but type 1 diabetes, take insulin, does not take any regular medication. On examination, mildly distressed, pulse is 90, blood pressure 118 by 70, respiratory rate 26, SpO2 94, temperature 37. On auscultation, there is a loud expiratory wheeze bilaterally. Temperature, you can see blood analysis, pH is 7.5, that means more. This is what, acidosis or alkalosis?
Alkalosis.
Alkalosis, because our pH is more. Whenever the pH is more, this is alkalosis. Whenever the pH is less, this is acidosis. So we are talking about alkalosis. Now you have to see that whether this is respiratory alkalosis or metabolic. They haven't given anything related to metabolic. That means we are talking about respiratory. So respiratory alkalosis means your carbon dioxide is going to be low. Okay. Whenever the carbon dioxide is high, that is respiratory acidosis. Whenever the carbon dioxide is low, that is respiratory alkalosis. So your patient is having respiratory alkalosis. This is the important category. Now, he is asking which of the following is the most appropriate initial step in the management. Now, how you are going to manage this patient? Initial step. You have to categorize the patient first. She is having exacerbation. She presents 2 hours history, worsening shortness of breath with wheeze. There is a mild symptom, not the severe one. She is mildly distressed. Saturation is 94%. And they haven't mentioned anything related to that she's not able to speak or anything like this. So more likely you are dealing with which category? Mild, moderate, severe?
Mild.
Mild
Mild.
category. Mostly mild to moderate, we can say, but mild category. So initial step, what should be the initial step for mild category among the options?
Inhaled budesonide formoterol.
Okay, let's see. So basically, this one, short-acting beta-2 agonist, these are the first-line treatment for the acute asthma exacerbations, which is, remember, this acute exacerbation. This is not maintenance therapy. I'm saying again and again, do not mix this acute and maintenance treatment together. This is the acute exacerbation in your emergency department. Patient comes to you, and this is a patient when you are discharging the patient at home management. So these are two different flowcharts. Remember these as such.
Okay.
You have to go through according to this patient. Okay, he is presenting to you with this symptoms. So that means you are talking about mild patient. So what you are going to do? Solbutamol, SABA therapy as a quick reliever therapy. So this is why the answer is SABA. Okay, that's why the asthma MCQs are tricky, because first of all you have to categorize the patient mild, moderate, severe. Then you have to see whether I'm talking about acute attack or I'm talking about maintenance therapy. So maintenance flowchart is different, acute attack is different. Okay, just make a visual memory of these flowcharts again and again and again so that you don't mix the two things together, because it's easy. You are able to interpret, but you are not able to apply to the questions. So you have identified this is a mild attack, you have identified that in acute attack you give SABA, you can give, but you have mixed the things with the maintenance flowchart. That's why you have choose this inhaled budesonide formoterol. Okay, so this is short-acting bronchodilator as a first-line therapy. Acute attack, systemic corticosteroid can be used early in a moderate to severe, because we have seen in both columns systemic steroids versus written oral steroid. Respiratory alkalosis, hypoxemia, this is acute attack. So we are talking about acute. Just remember, we are talking about this portion, this flowchart, okay? These things. So you have to remember these two separately. Now, next question is a 7-year-old
Ma'am,
boy.
answer was the last one.
This one?
Yeah, the
Yes,
last
nebulized
question's answer
salbutamol
was
or
that.
ipratropium. This one.
Okay.
Okay. Saba. Now, next is 7-year-old boy. He presents to emergency department by the parents. 2-day history of worsening asthma symptoms, including persistent dry cough and occasional shortness of breath. He has a medical history of asthma, managed with a regular preventer and as needed reliever. So he is already on some kind of medication. He's a diagnosed case of asthma. Now he presents to you with the dry cough and shortness of breath. On examination, he appears alert, able to speak in phrases. The pulse rate is 105, blood pressure is 110 by 75. Respiratory rate is 28, SpO2 is 96, and temperature is 36.8. No cyanosis, auscultation, widespread wheeze. He receives salbutamol burst therapy. See, they have managed acute asthma. Solbutamol burst therapy, 12 puff they have given by spacer repeatedly, 20 minutes interval. They have treated that patient as a moderate asthma because he was able to speak in phrases. Although their SpO2 was normal, but he was able to speak in phrases that mean moderate category, and they have treated that patient as a moderate category, 20 minutes interval plus steroid they have given. 4 hours after initial treatment, he appears comfortable, speaking in full sentence. That means he has shifted to the mild category. Pulse is 95, respiratory rate is 22, not required salbutamol for the past 3 hours. However, SpO2 is 92 in the room air with a minimal meso auscultation. So, what is the most appropriate management?
Discharge home.
Yes, so you have
Discharge.
to discharge that patient with the action plan. This we have discussed that mild hypoxia 90 to 94, this is acceptable if the patient is fulfilling the criteria for discharge. And you have to remember that duration, that 4 hours. 4 hours, if he is not needing any kind of medication for relieving, that he is good to discharge. This saturation is acceptable. This you have to remember. Then this important thing, silent chest. Silent chest on exacerbation. This is life-threatening asthma. That needs immediate ICU care. Bradycardia, bradypnea, that means low respiration, low pulse, lethargy. These are ominous signs that the patient is going into failure. Exhaustion, drowsiness, cyanosis, chest tightness, poor respiratory effort, less than 90%. This is life-threatening asthma. Life-threatening, they love to ask. They ask about these parameters. That's why I have put extra slide for life-threatening asthma. Silent chest is a very important feature. You have to remember this slide. Then we
Ma'am,
have,
in the question,
yes,
we for discharge 4 hours should be there, no? In the question it's 3 hours. So after 1 hour we can discharge.
yes, after 1 hour we can start, but they are particular about this saturation. They are basically giving you trick regarding saturation. But in RCH guideline, remember, there is clearly mentioned the duration and everything. So asthma is a very interesting if you make the concept so clearly. But if it becomes nightmare if you are just confusing the things together. So that's why it's you have to go through this topic again and again. Now, the important concept is asthma management during pregnancy. Okay. So, two questions regarding to this category is basically first of all, if the patient is a diagnosed case of asthma, she is taking some kind of medication. Then during pregnancy, are you going to change that medication or you are going to continue that medication? This is a very common concept. So, important thing is that all the asthma medication they are safe. Okay. So, whatever the patient is taking, she should take that medication as such. No need of change of medications according to specifically that condition. Okay, so this is an important concept. Then second important thing is that can you stop the medications of asthma if she's not taking any medication, like asthma is controlled, or she's saying that I do not want to take any medication, so what will you counsel that patient? So remember, the good control of asthma is more important rather than stopping the medication. So she needs medication. If she is taking regular medication, you cannot say that you can leave the medication due to that pregnancy condition. She needs medication. So whatever she is taking, she has to take as such. And even if she presents to you in emergency department with exacerbation or acute flare, you treat that patient exactly same like a normal patient. There is no hard and fast rule. There is no different guidelines. This is a normal patient. Okay. So just omit the condition and treat the patient as asthma. So remember, beta 2 agonists are safe. Steroids are also safe. Even she comes to you in a flare and she needs some kind of steroid therapy as a flare management, you will give steroid. Okay, so everything is same in pregnancy. There is nothing to be worried about it, because untreated asthma, there is a greater risk to the mother and fetus than side effect of the corticosteroid. That's why we can give steroids if there is a need of acute exacerbation. Initial management is going to be high flow oxygen, nebulized bronchodilator, ipratropium bromide before steroid. Basically, you will go into step up approach. You will not go for the rush towards steroid because steroid has side effect. So you will give bronchodilator, you will give ipratropium, but in case she needs a steroid as a flare therapy, you can give. But with steroid, you will have to monitor blood glucose, because if there is an increased chance of glucose derangement with the steroid therapy, and glucose is dangerous for this condition. So you have to look for gestational diabetes, blood glucose monitoring along with the steroid, but you can give. Okay, so this is a take home message. Then again, this is an important thing, that if a patient comes to you, this is the same thing. The 27-year-old woman, she is pregnant. Basically, she comes to emergency department with shortness of breath in last 24 hours. There is a severe asthma. She is using salbutamol inhaler. She reports wheezing and tightness, no fever, no productive cough. On examination, pulse is 110, temperature is high. Widespread wheezing is there. Peak expiratory flow is 55. Oxygen therapy you have given. Then the next important step. So remember, she is already taking salbutamol and she has come to you with a flare. So you can give oral prednisolone and nebulized salbutamol just like a moderate asthma or mild asthma, just like we treat as a flare. So steroid is absolutely safe. If she needs steroid, she can be given steroid. Okay, even inhaled, even oral, she can be given. This is basically a thing. So if we just summarize the things together, whatever we have learned so far, this is a take-home message that you should remember. SABA alone never recommended as a maintenance therapy. We are talking about maintenance. So maintenance, that means home treatment. Take home message that when you are sending the patient back to home with some kind of medication, do not give SABA alone. Either you give that LABA ICS combination or you give SABA reliever plus LABA ICS combination. That two flowcharts what we have discussed so far. So ICS formoterol, this is the preferred one. If you have to choose between the two, go for the ICS formoterol combination because it's easy for the doctor, it's easy for the patient to understand rather than you will say this is an inhaler you have to take on your reliever medication, this is an inhaler you have to take as a maintenance therapy. That will create mess. So just give a one inhaler whenever you need it. You take it 2 puff daily basis, and whenever you have emergency, take 1 puff additional. So it's easy to remember, it's easy to understand. So ICF formoterol, this is the preferred medication, and LABA monotherapy contraindicated in asthma. In no situation we have read this LABA monotherapy. This is absolutely out. Okay, this is never given. So only condition in which you can give SABA alone, we can write it as a one-liner note that only condition in which you can give SABA alone is basically your which
Mild
category?
exacerbation. Mild
Yes,
exacerbation.
exacerbation. Okay, so you have to remember is mild acute exacerbation. Only this is a condition that is allowing you for the prescription of SABA alone therapy. Otherwise, never give SABA alone, and LABA never in not never situation. Okay, so this is the only things you have to remember for your asthma management. Then the last point is this omalizumab. Omalizumab is basically monoclonal antibody. When you have like you have tried all the medications and the symptoms are not controlled and the patient is having very severe asthma on the regular basis and he is presenting to you with a more severe exacerbation again and again, and he is under specialist care and he needs some kind of medication, then you can use this monoclonal antibiotic therapy, which is omalizumab. So this is for severe allergic asthma when your IgE levels are more than 30. This is our condition when you have recent severe exacerbation in past 12 months that require more than one time your hospital admission or more than one exacerbation that requires systemic steroid, you can give this medication like this in past 1 year admission or exacerbation. Or the patient is under more than 6 months, he is under respiratory physician. That means the asthma is so uncontrolled that GP cannot control that patient. He has to visit again and again respiratory specialist. So these are the three indication in which you can give omalizumab. Okay, so omalizumab is a last resort for asthma medication, never preferred as a first line therapy. So that's all for the asthma management. Okay, I hope that has become summarized and easy for you guys because this is
I'm
a very
sorry.
important topic.
Uh,
Ma'am,
I'm
can you
sorry
just
to
repeat the
disturb.
flow chart?
Uh,
What
Excuse me,
what
ma'am.
are you asking? Yes.
Ma'am, can you just
Uh,
repeat once flow chart?
Ma'am, the flowchart, and actually I got
Flowchart
disconnected.
or acute
Summary part.
That
this
one.
okay. Okay, this is
Yes.
basically, remember, this is not emergency. Okay, the patient is not in an emergency department. This is a patient you are sending home. This is a maintenance flowchart. Okay, maintenance. So maintenance flowchart, remember, you have two options. You can use either of these flowchart direction. In one option, you are using SABA as a reliever therapy. Reliever mean when you are saying that James is your patient and you are saying, James, whenever you have acute exacerbation at home, this is a medication, take 2 puffs. Okay, as a reliever therapy. And in one patient you are giving this is your patient who is Jenny or any patient, and you are giving this inhaler that Jenny, whenever you have acute exacerbation, take this as a reliever therapy. So you have LABA ICS. So if one patient is taking SABA as a reliever, one patient is taking ICS formoterol as a inhaler reliever. So these are reliever options. These two patients are separate patients. Now comes maintenance therapy. That what you have given for the daily basis. This is a patient who is already taking stronger medication as a reliever therapy. So you have the option that at first step you give just SOS basis. That means you are saying, Jenny, whenever you need this medication, just take it. Otherwise, on daily basis, you do not need to take any kind of medication. So this is a first line therapy, that low dose as needed. But if the symptoms are not controlled, she comes to you after 2 weeks of follow up and she says that, doctor, I am having acute exacerbation and my symptoms are not controlled. So what you are going to do, earlier she was taking as needed medication. Now you say that you have to take this medication daily, same medication, low dose, but daily basis. Okay. Then she, after 2 weeks, she again comes to you, my symptoms are not controlled. So earlier you were giving low dose medication. You will say same medication, you will increase the dose, medium dose. Okay. Still not control, you will send her to the specialist. So this is a one flow chart. This is your patient journey. Just write it down to your patient. It will be easy to remember. This is your one patient who is taking LABA ICS combination. Okay. So LABA ICS, first of all, you prescribe that whenever you need it, then low dose daily, then medium dose daily, then you refer the patient. This was your first flow chart. Second flow chart, this is a patient who comes to you with a James. Okay. So James, you prescribe that you have to take a SABA as a reliever therapy. Okay, SABA as a reliever. But this is a very mild medication, so you have to put something as a maintenance therapy from a start. We are not saying that SABA take SOS basis. This is not recommended. SABA alone as a maintenance is not recommended in asthma now. So for this patient whom you are using SABA, these are the patients who come to you like, just say he is having asthma for the 10 years of age and he is taking SABA for a very long period of time. So he says that this is a very good medication and you are counseling the patient that guidelines has been changed and this is recommended now. But he says, no, doctor, I have this medication. I love this medication. I want to use this. So if the patient says that this is the preferred medication, otherwise the doctor now is prescribing this part of the flowchart. But because the guidelines has recently changed, there are many patients who still love to use the SABA because they are using this medication for a very long period of time. They have the confidence on this medication. So James tell you that, no, doctor, I have this medication for a very long period of time. I want to continue this medication. So what you are going to prescribe, you are saying guidelines has been changed. Okay, you can use this medication as a reliever therapy, but now on you have to use ICS as a maintenance therapy if this is your preferred medication. Okay, so remember it as such. So ICS as a maintenance low dose plus SABA as a reliever therapy. This is a first step. If symptoms not controlled, then same SABA as a reliever therapy, but just say because this was the preferred flowchart, you have start your own flowchart from here, from a second step. You have put the patient onto the ICS LABA maintenance low dose. Along with that, he's taking his own SABA reliever, which he loves to use. Okay, not controlled still, same flowchart. You have started ICS LABA maintenance medium dose. Along with that, he is using SABA reliever as needed. So this is easy, I think, to remember now. This is a James who loves to use SABA as a monotherapy because he is using for this medication for a very long period of time. So you let that patient use that medication, but at baseline you have added ICS. But after ICS symptoms not controlled, two flowcharts are exactly same. In one, you are prescribing LABA ICS combination, and one you are prescribing LABA ICS, but James is using SABA uh, due to his choice. Just remember like this. Okay. Now I think it's more
Yes, ma'am.
concise.
Thank you
Okay.
so much.
So you have to revise this again and again. And asthma questions are must to come in exam. There is must 3 to 4 questions of asthma. So you just go through the eMedicine question today. Then there will be a lot of concepts you are going to clear. So I think that's all for today. Otherwise, you will mix
During
the things together.
I had a
Yes.
doubt.
Yes. Tell me.
In the summary, when you were explaining the summary, I got disconnected for a few minutes. You were saying
Mhm.
SABA is used only when, as a single. When do we use that?
This one. Remember, this is one flowchart which we have just covered. This is a maintenance flowchart. Okay. In this, you are not using SABA alone. There is no option of SABA alone. SABA is out. Okay. This is a concept. Now, what are the conditions in which we only use SABA? So this is emergency flowchart. This is a second picture. Remember, asthma is a two pictures. One is the first flowchart, second is the this flowchart. So this is a patient who comes to you in emergency department and he is having mild exacerbation. Then this is the only situation you can use SABA alone as a reliever therapy. Otherwise, this is not SABA, this is not SABA, this is a combination therapy. Although in eMedicine there are so many questions in which they are using SABA plus steroid, but remember, according to guidelines, it is now recommended SABA alone can only be recommended in your mild exacerbation of asthma, not as a reliever therapy, not as a moderate severe therapy. And LABA alone, this is absolute contraindication. LABA alone is not recommended in any situation. Okay. So we have written these 2 lines at the end as a take home message. This one, that only condition in which you can use SABA alone is your mild acute exacerbation of asthma, and your LABA alone, this is contraindicated. Okay, remember this concept that LABA alone is a contraindicated. This is no guidelines they are mentioning LABA alone therapy. So that's all. Okay, any other questions?
Yes, ma'am. And ma'am, the omalizumab, what were the 3 indications?
What was the 3 indication for what?
Omalizumab.
Omalizumab. Okay. So omalizumab, we have 3 indications, which are basically telling you if a patient comes to you with the eosinophils more than 30, first of all. Okay. So more than 30 eosinophils, if the patient is having severe asthma and you have measured that the patient is having history of atopy and the more than 30 eosinophils, or the patient is having last 12-month history of one hospital admission, or patient is having acute exacerbation that requires systemic steroid, that means IV or oral or IM steroid in the last 1 year, or the patient is continuously under the care of respiratory specialist in the 6 months, because we have just seen that the asthma patients are treated by the GP. When he step up, step up, step up, when the things are out of control, then he referred the patient to the respiratory specialist. So if the patient is under the care for more than 6 months, he is under the care of respiratory specialist. That means the asthma is not controlled. He's having very bad control. So even that patient can be given omalizumab. So these are the 3 indications in which you can give omalizumab to the patient. Okay.
Thank you.
Okay. So that's all for asthma. Just go through this file. Sorry, I hadn't shared the slides previously, but I will definitively share it today. Then go through these files: COPD file, asthma file, and on weekend try to cover